Today we are going to be reviewing shock, sepsis, and multiple organ dysfunction. We'll start off with shock. So, what is shock? In general, all forms of shock are basically three words: impaired tissue perfusion. And this impaired tissue perfusion results in cellular, metabolic, and hemodynamic alterations that affect the body system as a whole. Also, it's important to understand that it really has to do with an imbalance between cellular oxygen supply and cellular oxygen demand. This imbalance can occur for a variety of reasons and eventually results in cellular dysfunction and death. There's this word or phrase called shock syndrome, and it captures all of the forms of shock, and they can be categorized into four stages. One is the initial stage, two is the compensatory stage, three is the progressive stage, and then four is the refractory stage. Also, shock can be broken down into four overarching categories. There's only three listed here, but there's actually four. One is hypovolemic, two is cardiogenic, three is distributive, and four is obstructive. And we'll talk about each one of these types of shock. So, the four stages of shock, let's talk about those. So, during the initial stage, cardiac output is decreased and tissue perfusion is threatened. Almost immediately, the compensatory stage begins as the body's homeostatic mechanisms attempt to maintain cardiac output. Also, blood pressure and tissue perfusion are the body tries to uphold those three things: cardiac output, blood pressure, and tissue perfusion. And it does it by a host of factors. Some of those things we've talked about in previous lectures. During the progressive stage, the compensatory mechanisms begin failing because of it just can't meet the tissue metabolic needs, and then the shock cycle is perpetuated. During the refractory stage, shock becomes unresponsive to therapy, and often this is considered to be an irreversible stage. As each individual organ systems die, multiple organ dysfunction sets in, and then what MODS is, or multiple organ dysfunction, it's really defined as a failure of two or more body systems. When this occurs, a patient is said to be in multiple organ dysfunction. Ultimately, this can lead down the road to death, and that's often the final outcome. Regardless of the etiologic factors, death occurs from ineffective tissue perfusion because of the failure of the circulation to meet the oxygen needs of the cells throughout the body. So let's do a quick quiz. What occurs during the refractory stage of shock? What occurs during the refractory stage of shock? So take a look at the answers. I'll give you a few seconds. And if you said D, then you are correct. The refractory stage of shock is recognized by its irreversibility. And so shock becomes unresponsive to therapy. That would be the correct answer. The patient with a mean arterial blood pressure less than 60 or with evidence of global tissue hypoperfusion is considered to be in shock. So that's a key number to remember. A mean arterial pressure less than 60 millimeters of mercury. Now, clinical manifestations vary according to the underlying cause of the shock and also the patient's response to shock. But global indicators of systemic perfusion and oxygenation, including serum lactate, arterial base deficit, serum bicarbonate, and central or mixed venous oxygen saturation levels can be good indicators for how a patient is doing in response to the treatments that you're giving or how they're compensating in shock. Inadequate cellular oxygenation with anaerobic metabolism and increased metabolic lactate production increase the serum lactate level. The level and duration of this hyperlactemia are predictive of morbidity and mortality, and management guided by lactate levels has been effective in improving outcomes. The base deficit is derived from the arterial blood gas, and it's also reflective of global tissue acidosis and is useful to assess the severity of shock. Studies have demonstrated that serum bicarbonate to be an equivalent alternative to arterial base deficit in predicting mortality in surgical and trauma patients. So this is a good number to key into, and that would be either the acid-base balance or the lactate or the bicarbonate level. And then finally we'll talk about SVO2. The use of mixed venous oxygen saturation, or SVO2, it's measured by means of a pulmonary artery catheter or a central venous oxygen saturation, so that's a SCVO2. They're very similar numbers, and they're measured with, one is measured with a pulmonary artery catheter, another is measured with a central venous catheter. And it allows for an assessment of the balance of oxygen delivery and oxygen consumption. And you all know that as when oxygen returns to the heart, you should have a concentration of roughly 70%, 70 to 75% return. So really, under normal circumstances at rest, you should only be using about 25% of your, 25 to 30% of your oxygen in your bloodstream. So let's take a look at the medical management of shock. The major focus of the treatment of shock is really to the improvement and preservation of tissue perfusion. And that's where we go back to our cardiac output equals heart rate times stroke volume formula, and then we target each one of those items within the stroke volume and optimize those. And as we look at these numbers over here, or the bullet points, we can see that's exactly what we're talking about. So cardiac output and hemoglobin levels are both parts of the formula for oxygen delivery. Fluid administration would be preload, blood would be preload, vasoconstrictor agents would be afterload, and then nutritional supplementation would and glucose would be to provide energy to the cells as they are fighting through a acidotic state, or an anaerobic state. All right. A little bit more about nursing management. The nursing management of a patient in shock is very complex and challenging. It does require an in-depth understanding of the pathophysiology of the disease that the patient has, and then anticipating the effects of each intervention, as well as a solid understanding of the nursing process. The psychosocial needs of the patient and family when dealing with shock are pretty important. These needs are based on situational, familial, and patient-centered variables. Nursing interventions for the psychosocial stress of critical illness, including providing information on the patient's status, and then also explaining procedures and routines, and providing support to the patient, are extremely important for the patient's care and also for the family's care. The consensus of all relevant professional organizations is that patients and families should be given the option of family presence when invasive procedures are performed or resuscitation is being performed. And we talked a little bit about this in lecture 2 of this quarter. So let's dive into hypovolemic shock. And if we had our little formula up here of cardiac output equals heart rate times stroke volume, and then stroke volume equals preload, afterload, and contractility, What we're targeting here would be preload, and hypovolemic shock occurs from inadequate fluid volume in the intravascular space. The lack of adequate circulating volume leads to decreased tissue perfusion and initiation of the general shock response. Hypovolemic shock is the most common occurring form of shock. Hypovolemic shock also can result from absolute or relative hypovolemia. Absolute hypovolemia occurs when there is a loss of fluid from the intravascular space. Relative hypovolemia occurs when vasodilation produces an increase in vascular capacitance relative to the circulating volume. Now, hypovolemia results in a loss of circulating fluid volume, ultimately. A decrease in circulating volume leads to a decrease in venous return, which results in a decrease in end diastolic volume, and you all know that end diastolic volume is preload. Preload is the major determinant of stroke volume and cardiac output. A decrease in preload results in a decrease in stroke volume and cardiac output. The decrease in cardiac output will lead to inadequate cellular oxygen supply and, ultimately, ineffective tissue perfusion. All right, so assessment and diagnosis in hypovolemic shock. So the clinical manifestations of hypovolemic shock depend on the severity of fluid loss and the patient's ability to compensate for that fluid loss. Clinical classes have been developed by the American College of Surgeons to help describe the levels of severity of hypovolemic shock. A simpler approach of classifying hypovolemic shock as mild, moderate, or severe is also commonly used. Class 1 or mild shock indicates fluid volume loss of about 15%, or an actual volume that would be about 750 cc's. So you're talking about, that's a little less than a six-pack. Actually, about half a six-pack. Class 2 hypovolemia occurs with a fluid volume loss between 15 and 30%, or 750 to 1,500 cc's. So you're talking about 1.5 liters of blood loss would be about 30% of a patient's blood volume. Hypovolemic shock that is class 3 occurs with a fluid volume loss of 30 to 40%, and so we're talking about 1,500 cc's to 2,000 cc's, and that's not quite half of someone's blood volume. Class 4 shock is considered severe shock and often is also referred to as refractory in nature and is usually irreversible and will lead to death. Assessment of the hemodynamic parameters of a patient in hypovolemic shock varies by stage, but commonly reveals a decrease in cardiac output and cardiac index. So, in hypovolemic shock, the major goal is to correct hypovolemia, and this is done through the administration of fluid blood products. In particular, if a patient is bleeding, you want to replace the blood loss with what they're bleeding, and that would be plasma and red blood cells and also platelets. Management of the patient in hypovolemic shock requires continuous evaluation, and so anytime you give volume, then you'll be reassessing and those parameters. So you're going to be looking at heart rate, blood pressure, you're going to be looking at central venous pressure, you're going to be looking at the patient's level of consciousness, and so forth. Nursing interventions include minimizing fluid loss, administering fluid replacement, and then assessing response to therapy. Another important point is you're going to be monitoring the urine output, and as you correct hypovolemia, you should see that the urine output picks up. We call that the poor man's Swan-Ganz catheter. All right, now we're moving into cardiogenic shock. Cardiogenic shock is the result of failure of the heart to effectively pump. We covered we covered heart failure and also myocardial infarction, and really cardiogenic shock results because of primarily those factors that we covered in those sections. So you all should have knowledge on that now, and so I'm not going to go into great depth here, but the key is that you have mechanical failure of the pump. So on that formula, cardiac output equals heart rate times stroke volume, and then preload afterload contractility. We're really focused in on contractility, so the heart cannot effectively pump, and depending on where the pump is failing, we have to do a few different things. So first, it's important that if the left side is failing, then we want to reduce the SVR. We want to reduce blood pressure down to an appropriate level so that the heart does not have to work as hard to pump blood out. And then we also want to optimize the stroke volume with just judicious fluid administration. We don't want to overload the heart because then we'll get backup and congestion into the lungs. But then we have to just judiciously give fluids. If it's a solely right pump problem, then that's managed a little bit different. We had talked about that previously in a different lecture. Okay, some of the things that we're going to be measuring in cardiogenic shock. It is nice to have a pulmonary artery catheter so that we can monitor the pulmonary artery wedge pressure, or another way to do that is the pulmonary artery diastolic pressure, and just take 2 points off of your pulmonary artery diastolic pressure to get an estimation of your pulmonary artery wedge pressure. And then of course you have your standard parameters of blood pressure and so forth. Another thing we can use is the SVO2 to look at oxygen supply and demand. All right. So clinical manifestations really depend on the etiologic factors, the patient's underlying medical status, and the severity of the shock state. Manifestations may be caused by failure of the heart as a pump or related to the overall shock response. Initially, you will see that the patient, clinical manifestations reflect the decline in cardiac output. The patient may complain of chest pain, tachycardia may develop to compensate for the low cardiac output, and then respiratory rate will increase to try to improve oxygenation. ABG values typically indicate respiratory alkalosis because of the increased respiratory rate. And then as the left ventricle fails, auscultation of the lungs may disclose crackles or rhonchi, indicating pulmonary edema. Hypoxia will occur, and assessment of the hemodynamic parameters of a patient in cardiogenic shock will reveal a decrease in cardiac output and index. Usually when we're talking about severe cardiogenic shock, it's going to be less than 2.2 liters per minute per meter squared. And in the presence of an elevated pulmonary artery pressure greater than 15, this would really indicate a left ventricular failure. Echocardiography can be used to confirm the diagnosis of cardiogenic shock and to provide a non-invasive method for doing that. And then of course your pulmonary artery wedge pressure or pulmonary artery occlusion pressure and ejection fractions often clarify the etiologic factors in this case. As compensatory mechanisms fail and ineffective tissue perfusion develops, other clinical manifestations may appear, such as myocardial ischemia, and as the ischemia progresses, there'll be evidence that you'll see this as in increased heart rate, dysrhythmias, and chest pain, and then pulmonary function will ultimately deteriorate and lead to respiratory distress. Now, ABG values during this phase reveal respiratory and metabolic acidosis and hypoxemia. And at this stage, ultimately, renal failure will occur, and then also you'll see decrease in level of consciousness due to cerebral hypoperfusion. All right. So, to wrap up cardiogenic shock, the treatment of the patient in cardiogenic shock requires an aggressive approach. The major goals of therapy are to treat the underlying cause, enhance the effectiveness of the pump, and improve tissue perfusion. This approach includes identifying and treating the etiologic factors of cardiac failure and administering pharmacologic agents or using mechanical devices to enhance cardiac output. Now, prevention of cardiogenic shock is one of the primary responsibilities of the nurse in the critical care area, and preventative measures include the identification of patients at risk, facilitation of early reperfusion therapy in acute MI, and then frequent assessment and management of the patient's cardiopulmonary status. The patient in cardiogenic shock may have any number of nursing diagnoses depending on the progression of the process of the disease. Nursing interventions include limiting myocardial oxygen demand, enhancing oxygen supply, maintaining adequate tissue perfusion, providing comfort and emotional support, preventing and maintaining surveillance of complications. Effective nursing management of cardiogenic shock requires precise monitoring and management of heart rate, preload, afterload, and contractility. Patients who require mechanical device therapy, patients who require mechanical device therapy, such as the intra-aortic balloon pump or left ventricular assist device, need to be observed frequently for complications, which may include infection, bleeding, thrombocytopenia, embolus, hemolysis, stroke, device malfunction, and there are a few others. We don't want to forget about SIRS and sepsis. Those machines can sometimes cause problems. Okay, moving on to anaphylactic shock. Anaphylactic shock is a type of distributive shock, and it is the result of an immediate hypersensitivity reaction. It is life-threatening, and it requires immediate intervention. The severe and systemic response leads to a decrease in tissue perfusion and an initiation of the general shock response. Now, anaphylaxis is serious. It's an allergic reaction caused by an immunologic antibody-antigen response or non-immunologic activation of mast cells and basophils. Some of the triggers that you probably have heard of are food additives, diagnostic agents such as contrast, biologic agents, environmental agents, medications, venoms, and also there may be some physical factors that can also. Some people actually might have also idiopathic anaphylaxis. Oh, I flipped slides. Sorry about that. Sorry. There we go. My apologies. So, nursing interventions include administering epinephrine, facilitating ventilations, administering volume replacement, providing comfort and emotional support, and then maintaining surveillance for recurrent reactions. It's also important that we prevent and maintain surveillance for complications of any of the treatments that we do. Patient education is paramount to avoid the precipitating allergen, and then education about how to recognize and respond to future episodes, including self-administration of epinephrine, is essential to prevent a future life-threatening event. All right, so neurogenic shock. Neurogenic shock is another form of distributive shock, and it results because of a loss of or a suppression of the sympathetic tone. And typically what we're talking about here is that there's a disruption in the sympathetic nervous system. The problem can occur as a result of interrupted impulse transmissions or blockage of the sympathetic outflow from the vasomotor center in the brain. The most common cause is actually spinal cord injury. So the loss of sympathetic tone results in a massive peripheral vasodilation, and then that peripheral vasodilation causes an inhibition of the baroreceptor response, and that impairs, and it also impairs thermoregulation. Ultimately, what this leads to is arterial vasodilation, and then a decrease in SVR, and subsequently the blood pressure falls. Venous dilation leads to a relative hypovolemia, and so fluid pools in the venous system, and you get a decreased venous return, that means basically your end diastolic volume or preload is greatly reduced, and this causes a decrease in your stroke volume, which ultimately decreases your cardiac output. The fall in blood pressure and cardiac output leads back to our three words: inadequate tissue perfusion. So the loss of sympathetic tone and the inhibition of the baroreceptor response also can cause a relative bradycardia or bradycardia. So you may see slow heart rates in these types of patients. Now, the patient in neurogenic shock characteristically presents with hypotension, bradycardia, and warm, dry skin. And that's in contrast to the patient with hypovolemic shock, who would present with hypotension, tachycardia, and then cool, pale, and diaphoretic. So that's one of the distinguishing factors between patients that are in hypovolemic shock versus distributive forms of shock. In particular, this is neurogenic shock. So, assessment of the hemodynamic parameters of a patient in neurogenic shock will reveal a decrease in cardiac output and index, and then venous dilation. And so we will be measuring, we can use the central venous pressure to measure this. Vasodilation of the arterial system causes a decrease in afterload, and this will be evidenced by a decrease in SVR. So the treatment for neurogenic shock requires a careful approach. The goals of therapy are to treat or remove the cause, and then prevent cardiovascular instability and promote optimal tissue perfusion. So hypovolemia is treated with careful fluid resuscitation, and the minimal amount of fluid is administered to ensure adequate tissue perfusion. The patient is carefully observed for fluid overload, and then vasopressors are used as necessary to maintain blood pressure and organ perfusion. So a drug that you will often see given in states of neurogenic shock, so norepinephrine would be one, dopamine may be one, and then also neosynephrine. Neosynephrine would be strictly alpha in its alpha agonist, and it will cause vasoconstriction only. So this would be one that would be very effective. Okay, nursing interventions include include treating the hypovolemia and maintaining tissue perfusion, and also maintaining normothermia. These patients will frequently have dysregulation of their body temperature. And then, of course, we'll be monitoring for dysrhythmias, and then providing emotional support and comfort, and then monitoring for complications. Okay, let's do a quick quiz. Which kind of shock occurs from inadequate fluid volume in the intravascular space? So we have which kind of shock occurs from inadequate fluid volume in the intravascular space. And if you said C, then you are correct. So we're talking about fluid volume not being in the intravascular space, and that would be hypovolemic shock. Hypovolemic shock. So we're moving into severe sepsis and septic shock now. And so the severe sepsis is basically it occurs when microorganisms invade the body and initiate a systemic inflammatory response. This is a host response that often results in perfusion abnormalities and organ dysfunction. And when it involves the organs, that's when it's really called severe sepsis. And eventually, hypotension will result in what we call septic shock. The primary mechanism of this type of shock is the maldistribution of blood flow. And so this severe sepsis and septic shock are considered to be a distributive form of shock. So sepsis is caused by a wide variety of microorganisms, all the way from gram-negatives to fungus and viruses. The respiratory system is the most common site of infection, and gram-positive bacteria are the predominant cause of sepsis. Now, sepsis and septic shock are associated with a wide variety of intrinsic and extrinsic precipitating factors, and all of these factors interfere directly or indirectly with the body's anatomic and physiologic defense mechanisms. And really, all critically ill patients are at risk for septic shock because of all the lines that we put in them and the tubes that we put in them, and they have a decreased immune system as well. Okay. So the syndrome of septic shock So the syndrome encompassing severe sepsis and septic shock is very complex, and it really is initiated by the microorganism that enters the body and then stimulates the immune system. In a host pathogen interaction, both the invading organism and the injured tissue release intracellular proteins, and then when this occurs, it causes an initial reaction locally, and then infection is contained and eradicated by the host's immune system. But when contaminant fails, the result is a systemic release of the pathogenic activated cells and mediators, including cytokines, that initiate a chain of complex interactions that lead to what we call systemic inflammatory response syndrome, and that's abbreviated SIRS, S-I-R-S. With the systemic activation, physiologic and pathophysiologic events occur that affect clotting, blood flow to the tissues, and then also you have a systemic imbalance between cellular oxygen supply, and then ultimately you have cellular hypoxia, damage, and then cell death that occurs. Some cells can actually go into kind of a hibernation state. Hallmarks of severe sepsis are endothelial damage throughout the vascular system, and then coagulation dysfunction. We used to call this disseminated intravascular coagulation, but now we just call it coagulation dysfunction. Significant alterations in cardiovascular hemodynamics are caused by the activation of inflammatory cytokines and endothelial damage that occurs. Activation of the central nervous system and endocrine systems occur as part of this overall response. Excuse me. Now, the metabolic alterations occur as a result of the central nervous system, endocrine nervous system, and then also cytokine activation. Metabolic derangements include an inability of the cells to use oxygen even if blood flow is adequate. So the exaggerated systemic inflammatory response results in cell death, via both the ischemic necrosis and, to a large degree, apoptosis. If unabated, this situation will ultimately result in multiple organ dysfunction and death. So, let's talk a little bit about assessment and diagnosis of patients in severe sepsis and septic shock. Effective treatment of severe sepsis and septic shock depends on timely recognition. The diagnosis of severe sepsis is based on the identification of three conditions. Known or suspected infection, that's number one. Number two or more of the clinical indications of SIRS, or the systemic inflammatory response, and evidence of at least one organ dysfunction. So let's go back over those three key factors again, the three conditions that are needed to be diagnosed with severe sepsis. Number one, known or suspected infection. Number two or more clinical indications of SIRS. And three, evidence of at least one organ dysfunction. If you'll go to box 3516 in your book, there's an expanded list of the diagnostic criteria for sepsis, and you should review that. As well, the box 3517 goes over the clinical manifestations of septic shock. Now, the two most common organs to demonstrate dysfunction in severe sepsis are the, you guessed it, cardiovascular system and the lungs. The patient in severe sepsis or septic shock may present with a variety of clinical manifestations that may change dynamically as the condition progresses. Now, during the initial stage, massive vasodilation occurs in the venous and arterial beds. The heart rate will go up, and this will cause an increased sympathetic nervous system, metabolic system, and adrenal gland stimulation. In the lungs, ventilation and perfusion mismatching develops as a result of pulmonary vasoconstriction and also the formation of pulmonary microemboli. The level of consciousness starts to change as a result of decreased cerebral perfusion, and then immune mediator activation. So I should back up here. So the level of consciousness changes for multiplicity of reasons. One being a reduced perfusion to the cerebrum. Another would be the immune mediator activation. The third would be hyperthermia, and then the fourth would be lactic acidosis. Your ABG values initially will reveal hypocarbia, so the patient will be hyperventilating. It will show hypoxemia, so you'll have a PaO2 that's going to be less than 60. And then you'll see a metabolic acidosis. As impaired tissue perfusion develops, a variety of other clinical manifestations will appear that will indicate the patient is developing multiple organ dysfunction. So now let's talk about the medical management of severe sepsis and septic shock. The goal of treatment is really to reverse the pathophysiologic responses, control the infection, and then promote metabolic support, and then let the body heal itself. But we have to identify the organism and treat it with antimicrobials. There is this thing out now. It's another bundle. We call it the sepsis resuscitation bundle. And it should be implemented within the first 6 hours. And the sepsis management bundle should be implemented within the first 24 hours. The patient in severe sepsis or septic shock requires immediate resuscitation of the hypoperfused state, and often they will require intubation and mechanical ventilation. You'll refer back to the conversation just a second ago. The two organs that are most affected are the lungs and the cardiovascular system. So you can see that we're going to be going after our cardiac output equals heart rate times stroke volume. preload, afterload, and contractility. We're going to optimize all of those things. And then also we're going to provide intubation and mechanical ventilation to support the ventilatory system and also to enhance oxygen delivery to the alveoli. A key measure in the treatment of septic shock is finding and eradicating the cause of infection, and low dose, I was going to talk about low dose intravenous corticosteroids, but that's now been shown to be not effective and could be harmful, so we won't talk about corticosteroids in relation to sepsis and septic shock. So oftentimes the patient will develop hyperglycemia, and so these patients may need to be on intravenous insulin to maintain blood glucoses of less than 180 milligrams per deciliter, and then you would like to keep the level between 150 and 180. These patients also, because they have such an increased metabolic rate, do need to get nutritional therapy, so nutrition should be started very soon, and then protein is very important. So those are some of the key recommendations for medical management of patients in severe sepsis and septic shock. So let's now talk about some of the prevention and management related to severe sepsis. So nursing recommendations to complement the Surviving Sepsis Campaign guidelines have been recently published, and they focused on infection prevention and then transmission and early recognition and treatment of severe sepsis and septic shock. The measures that were identified revolve around risk and risk reduction, looking at risk factors, including exposure to pathogens. Early identification will allow early treatment and decrease in mortality. The patient in septic shock may have any number of nursing diagnoses, and nursing interventions include early identification of the sepsis syndrome, administering prescribed fluids and medications, nutrition, providing comfort and emotional support, and then surveillance for complications. All right, let's do a quick quiz. So, septic shock is caused by which source? And I'll just let you take a look there. Give you a few seconds. And this was a pretty easy question, I think. And hopefully you all got answer C. That's the correct answer. So septic shock is caused by microorganisms. Okay. So allergens would be anaphylactic shock. A loss of sympathetic tone would be neurogenic shock. And then non-immunologic activation of mast cells would be another type of anaphylactic shock. Okay. So moving on to multiple organ dysfunction. This is the progression from, first we had SIRS, and then we have, SIRS is really, sepsis is basically SIRS with a source of infection. And remember, SIRS is a systemic inflammatory response syndrome. And you should look up SIRS and look at the definition and the different factors that determine that. And then sepsis, again, is SIRS with a source of infection. And third, we have septic shock is sepsis with shock. And you have the inflammatory response, which ultimately leads to massive vasodilation, and then a reduction in afterload and venous pooling of blood. And it's primarily caused by the bacteria or whatever pathogen is in the bloodstream. And now we have the progressive end stage of that, and that would be multiple organ dysfunction. Over the past 2 decades, critical care professionals have witnessed the emergence of a new clinical syndrome called multiple organ dysfunction. in critically ill patients. And we take such good care of these patients with septic shock, they often survive, and then we see them as they go into multiple organ failure, often before they would simply die. And now we restore their cardiac output, and we maintain perfusion. However, the organs become damaged and lose hemostasis, and they have tissue damage within the organ itself because of the bacterial debris and inflammatory processes, and that leads to multiple organ dysfunction. So multiple organ dysfunction survivors may develop all kinds of problems, including generalized polyneuropathy, and also a form of chronic pulmonary disease. They also can go into ARDS, and all those things will complicate their recovery. So multiple organ dysfunction really is simply defined as dysfunction of two or more organs in the setting of sepsis. Okay. So moving on to the pathophysiology, we touched on this a little bit, but really multiple organ dysfunction results from an altered regulation of the patient's acute immune and inflammatory responses. The definitive clinical course of secondary multiple organ dysfunction has not been really fully identified, and organ dysfunction may occur in a sequential or progressive pattern. Certain cellular and biochemical activities evoke the inflammatory and immune responses implicated in SIRS and MODS, and the mediators associated with SIRS and MODS can be classified as really four primary things: inflammatory cells, biochemical mediators, plasma proteins, and actually three, and plasma protein systems. Some of the other things that cause inflammation are the neutrophils, macrophages, monocytes, mast cells, and platelets, and all these things mediate the systemic inflammatory response through the production of cytokines. And during SIRS and MODS, neutrophils are activated, and systemically they damage normal cells in addition to killing the bacteria. Monocytes and macrophages normally perform three major functions, and that would be, and it's relative to the inflammation, and that would be they process antigens, and they present those antigens to the bacterial phagocytes, and this ultimately provides mediation for the destruction of those bacterial, or the invader. Mast cells are found in all body tissues, especially those adjacent to blood vessels, and when physical injury occurs or chemical agents and immunologic infectious causes, they activate mast cells and produce mediators through mast cell degranulation. And then new synthesis that have systemic and local effects. Lymphocytes adhere to and are sequestered in the microvascular endothelium, and then stimulated T and B lymphocytes produce cytokines such as interleukin 1 and 2, which activate other inflammatory cells. The endothelium is a unicellular layer that lines the vascular system, and during SIRS and MODS, the endothelial cells become targets for leukocytes-derived mediators, and they become dysfunctional because of this. And it's a multiplicity of factors, and it has to do with the prothrombotic and pro-inflammatory and vasoactive mediators that we mentioned above. Okay. Some other inflammatory mediators that you may hear talked about with endothelial damage include endotoxin tumor necrosis factor, or TNF, interleukin 1, and then PAF. These mediators also recruit and activate neutrophils, and they complement and perpetuate the destruction of the endothelium. So, ultimately, what this leads to is a destruction of cells, and there's multiple biochemical inflammatory mediators that play a role in this process, and we've talked about a lot of those. One of the ones we haven't mentioned was reactive oxygen species, and they are produced in excessive amounts during critical illness, and these reactive oxygen species, really they're free radicals that damage organs and can worsen multiple organ dysfunction. Another culprit that we've seen talked about in the literature is tissue necrosis factor, and the TNFA is a polypeptide that is released from macrophages and also lymphocytes in response to endotoxin. And the endotoxin, we're talking about the bacterial or viruses or tissue injury can cause this release of endotoxin, and then it will spur the release or production, or I should say the release from macrophages of TNF alpha. And this TNF alpha causes widespread destruction in most organ systems when it's abundant. And what this leads to is the systemic inflammatory response. You'll see fever, hypotension, decreased organ perfusion, and increased capillary permeability. This will be reflected in acute respiratory failure, acute renal failure, liver failure, and so forth. Okay. The other culprits that you'll often hear talked about in the literature are the interleukins, the platelet activating factors that will lead to microemboli, and then arachidonic acid metabolites and proteases. Okay. Now, let's talk a little bit about assessment and diagnosis of gastrointestinal dysfunction. So secondary to multiple organ dysfunction is a systemic disease with other specific manifestations. Organ dysfunction is influenced by numerous factors, including organ host defense function, response time to the injury, metabolic requirements, organ vasculature response to vasoactive medications, and a host of other factors. The gastrointestinal tract plays a very important role in multiple organ dysfunction. Normal gut flora and the gut environment are altered in patients with severe sepsis. Healthy probiotics are decreased in a surge state, and pathogenic organisms proliferate within the gut. With microcirculatory failure to the gastrointestinal tract, the gut's barrier function may be lost, and this leads to bacterial translocation, and then this will cause a sustained inflammation, endogenous endotoxemia, and then worsened multiple organ dysfunction. The translocation of gastrointestinal bacteria is referred to as leaky gut, and this is when it actually leaks into the systemic circulation and initiates and perpetuates the inflammatory response seen in critically ill patients. Lastly, the oropharynx of a critically ill patient becomes colonized with potentially pathogenic organisms from the gastrointestinal tract, and the pulmonary aspiration of these colonized secretions presents an inflammatory focus that can contribute to the and compound the pulmonary dysfunction that is seen in multiple organ dysfunction. So the hepatobiliary dysfunction that occurs is, well, as you know, the liver plays a vital role in host homeostasis, and the overall inflammation that occurs in multiple organ dysfunction is the liver plays a role in that. And the liver responds to sustained inflammation by selectively altering carbohydrate, fat, and protein metabolism. And consequently, hepatic dysfunction threatens the patient's survival. Common causes of liver failure in critically ill patients are infectious in nature often, and can relate to cholestasis and hepatocellular injury in response to the toxins, and actually the toxins themselves. Now, the liver and gallbladder are extremely vulnerable to ischemia, or I should say a lack of oxygen, and so in states of systemic inflammatory response, the liver will often become hypoperfused and then will become damaged and will become one of the victims of multiple organ dysfunction. Okay. So, let's talk a little bit about pulmonary dysfunction that's seen in multiple organ dysfunction. So the lungs are frequent and early targets of organ dysfunction, and this is primarily mediated by the inflammatory response that is seen. The symptoms that you're going to see are very similar to other acute respiratory distress types of syndromes. So this is going to be caused because of the sepsis. So ARDS does have a direct association with multiple organ dysfunction, and it usually occurs 24 to 72 hours after the initial insult, when the patient develops, goes into septic shock, and then the lungs will fail within the first 24 to 72 hours. Now, the mediators associated with ARDS include primarily the inflammatory cells, such as polymorphonuclear cells, macrophages, mast cells, and endothelial cells, and the toxins themselves, and all those, that long list of pro-inflammatory cytokines that you saw earlier. So ultimately, this is going to lead to the damage of the capillary alveolar membrane, and this will cause that small thin membrane to become leaky, and then you'll have fluids that will collect and proteins that will collect inside the alveoli, and then you'll have impaired oxygen exchange and pulmonary edema. Kidney dysfunction is also seen with multiple organ dysfunction. The kidneys are susceptible to states of ischemia, and you may see acute tubular necrosis, and this is going to be reflected initially as a decrease in urinary output as renal perfusion is decreased, and early it is likely caused by just simply a decrease in renal perfusion, but late is going to be because of the injury and ischemia to the kidneys. When you have a continued low urine output, it may very well be because the kidney is no longer functioning properly. So it's really important to recognize acute kidney injury early and to maintain appropriate hemodynamics during that time, and treat the underlying infection. Okay. And finally, the cardiovascular system. The cardiovascular system, its response to SIRS or sepsis is primarily myocardial depression, decreased right atrial pressure, and then also decreased SVR. So you're going to see that the venous capacitance is going to increase. Cardiac output will initially increase, as well as the heart rate, and then as the sepsis turns into septic shock, you'll see that reverse and cardiac output will go down, and then you'll have myocardial contractility will be reduced, and then SVR will continue to be reduced. And then sometimes the ventricles can even dilate, and you can have the patient will go into cardiogenic shock as well. So we don't have a slide for it, but I would like to mention the most common manifestations of the hematologic dysfunctions that sometimes are seen in sepsis or MODS, and they have to do with thrombocytopenia, coagulation abnormalities, and also anemia. The most severe is coagulation, and when dysfunction of the coagulation system occurs, we can see the onset of disseminated intravascular coagulation, or DIC, and low platelet counts and elevated D-dimer concentrations, and also fibrin degradation products are the clinical indicators. So that's, I think, an important feature to remember, is that patients who are in multiple organ dysfunction, or SIRS or multiple organ dysfunction, may have disturbances in their coagulation ability, and the tests that we perform that will help to identify problems would be the platelet count, the D-dimer, fibrinogen degradation products, and those are going to be the three primary things that you'll measure to determine if the patient is having DIC. Okay, so let's move on to medical management. And first and foremost, we have to identify and treat the infection. That's of paramount importance. And so that's going to be done through blood cultures. Initially, you will need to provide empiric treatment, but we'd like to find the source of the infection and then treat it with appropriate antibiotics. Next, for medical management, would be the maintenance of tissue oxygenation and then nutritional and metabolic support. So patients who are in multiple organ dysfunction have an imbalance between oxygen delivery and oxygen demand, and so we have to try to balance that out, and we do that with our formula: cardiac output equals heart rate times stroke volume, also taking into account that hemoglobin levels play a factor in oxygen delivery, so we want to make sure that we're monitoring the hemoglobin levels closely and ensuring that the patient has enough hemoglobin to carry oxygen. And then we will be treating with fluids as appropriate. We'll be maintaining systemic vascular resistance as appropriate. And if we have any kind of cardiac dysfunction, providing support with medications that will augment contractility would be the focus. Okay. So prevention measures include a multitude of assessment strategies to detect early organ dysfunction, and patients who continue to experience sites of inflammation, septic foci, and inadequate tissue perfusion may be at higher risk. So some of the key preventative measures that we can take to ensure that we don't spread any kind of disease would be straight up hand washing hygiene, aseptic technique use, and then understanding how microorganisms can invade the body through the different tubes and lines that we place, and just simply being aware of the lines and tubes we placed and if they may be at risk for infection. So nursing interventions to prevent the development of infection include oxygen delivery and limiting tissue, check. Nursing interventions include preventing the development of infection, facilitating oxygen delivery and limiting tissue oxygen demand, facilitating nutritional support, providing comfort and emotional support, and then finally preventing and maintaining surveillance of complications. Patients should be assessed closely for inflammation and infection, and then strict adherence to standards and practice in relation to preventing infection should be maintained, along with preventing ventilator-associated pneumonia, and then measures that limit tissue oxygen consumption, such as analgesics and sedatives, and then making sure the patient's comfortable and limiting activities. Those are all things that will help in prevention. Okay. So, we've come to the end of the lecture. The next 6 slides are summary slides for each section, and so I'll go through these summaries with you. So, shock is an acute, widespread process of impaired tissue perfusion. That's, if you can just remember the 3 words, impaired tissue perfusion or inadequate tissue perfusion, you will understand shock. And no matter the form of shock, it's always that, impaired tissue perfusion. The 4 main causes are hypovolemic, cardiogenic, distributive, and obstructive. So you'll see here that obstructive is not listed. However, the 2 types of obstructive shock are seen in trauma patients, and that would be tension pneumothorax and then also cardiac tamponade, and as well one more that is a non-trauma in nature, and that would be pulmonary embolism. It is considered a form, especially a saddle pulmonary embolism, is considered a form of obstructive shock. And obstructive shock simply means that blood flow is being obstructed and cardiac output is lost, and that results in shock. So we have stages that are associated with shock, and those would be the initial, compensatory, progressive, and refractory. In hemorrhagic shock, there's a slightly different categorization, and that's going to be on a slide here shortly. So it's important to key into the MAP, or the mean arterial pressure. Anything less than 60 is considered to be global hypoperfusion, and it should be managed aggressively. And we should determine the cause of the shock. Management also does focus on supporting oxygen delivery, and then prevention of shock is primary responsibility of critical care nurses. So hypovolemic shock results from a loss of circulating volume. That may be from bleeding, or it could be from dehydration or other sources of fluid loss from the intravascular space. Initial hemodynamic parameters that you'll see a decrease in cardiac output, a decrease in central venous pressure, and also pulmonary artery occlusion pressure, and then an increase in systemic vascular resistance. This is treated by identifying and stopping the source of fluid loss, and then also administering fluids according to what type of fluids they're losing. Nursing interventions that you should key into are minimizing fluid loss, administering volume replacement, assessing therapy response, and then providing support, and then preventing and watching for complications. Cardiogenic shock is really pump failure. So the heart is not pumping effectively. So again, with all the forms of shock, you're going to see a decrease in cardiac output, In this case, you're actually going to see an increase in pulmonary artery occlusion pressure and CVP, and an increase in in systemic vascular resistance. The medical management revolves around restoring the pump and administering medications that will enhance cardiac output. Nursing interventions should be addressing limiting myocardial oxygen demand, enhancing myocardial oxygen supply, maintaining tissue perfusion, and then providing support, and then also, you're always going to get this, preventing and watching for complications. Anaphylactic shock results from an immunologic antibody antigen activation, or also a non-immunologic activation of mast cells and basophils, and release of biochemical mediators. Again, you get a decrease in cardiac output. In this case, you'll have a decrease in right atrial pressure, or CVP, and also pulmonary artery wedge pressure, because we have blood pooling in the venous system. You will also see a decrease in systemic vascular resistance, along with that pooling. The medical management is going to revolve around removing the offending antigen, reversing the effects of the biochemical mediators of the anaphylactic shock, and then promoting tissue perfusion. Nursing interventions are going to revolve around, in particular, administering epinephrine, and that's going to help reverse the vasodilation effects that are occurring throughout the periphery. Also, we're going to facilitate ventilation and administer any volume fluid replacement that's needed, provide comfort, and then, again, watch out for the complications of the shock and also of the treatments that we're giving. Neurogenic shock results from a loss of the sympathetic tone, primarily due to a spinal cord injury, and then so basically you lose sympathetic outflow. This will lead to also, again, just like the other forms of shock, a decrease in cardiac output. In this case, you see a decrease in CVP, or right atrial pressure, and left atrial pressure, and then a decrease in a decrease in systemic vascular resistance, and a decrease in heart rate. Sometimes the decrease in heart rate may be relative and hard to detect. Medical management is going to prevent cardiovascular instability and promote tissue perfusion. This is going to be performed by administering medications that will cause vasoconstriction, and then also medications that may need to be given to increase heart rate. Nursing interventions will focus on treating any hypovolemia that may be present, and then maintaining normothermia, and then treating dysrhythmias, and maintaining perfusion of the tissues through medications such as neosynephrine, dopamine, things that are going to cause vasoconstriction. Norepinephrine is another common one. Any good nurse is going to promote comfort and emotional support, and then monitor for complications. So now we move into septic shock, another form of distributive shock. This results from the systemic inflammatory response due to microorganisms entering the body. Hemodynamic parameters, we have the decreased cardiac output again. We've got a decrease in CVP and pulmonary artery occlusion pressure. We have a decrease in systemic vascular resistance, and we will see an increase in heart rate. So the key here is reversing the pathophysiologic responses that are seen in septic shock, controlling the infection with antibiotics, and then promoting metabolic support. We want to identify we'd like to identify sepsis early, and this is treated with aggressive fluid management and antibiotics, and we will provide support to the cardiac system with vasopressors if needed. But first, we should always correct the volume problem first. And of course, we'll be promoting comfort and emotional support while monitoring for complications. The systemic inflammatory response, as you all know, is an intense host response characterized by generalized inflammation in organs remote from the initial insult. So, the consequences, you have uncontrolled activation of inflammatory cells that ultimately cause damage to the vascular system, or the endothelium specifically, and then a disruption in the immune cell function, hypermetabolism, maldistribution of blood volume. And this will lead to, if not corrected, will lead to multiple organ dysfunction. And organ dysfunction is influenced by numerous factors, and the response time to injury. The quicker we respond, the more likely that multiple organ dysfunction can be stopped and we can prevent it from occurring. Medications can be given to help promote perfusion to the tissues, and also volume replacement is a big factor of that. So the collaborative management, as mentioned before, is fluid resuscitation, hemodynamic support, prevention and treatment of infection, maintenance of tissue oxygenation, nutritional and metabolic support, comfort care, and then also preservation of individual organ function.